So we're going to go into a conversation about diversity, and the panel is called Diversity 3.0, Advancing Diversity and Inclusion Within Medical Education and Medicine. So I'm Hugo Campos, and I'm going to quickly just recap our panelists. Robert Trevino, whom you just heard from, he's a PhD researcher and MD candidate. At Rush Medical College, I should say Dr. Robert Trevino, I apologize. At Rush Medical College, and 2017 Medicine X Student Leadership Program awardee. We have Eloisa Domingo Snyder, who's a Senior Director of Diversity and Inclusion and Deputy Chief Diversity Officer at Johns Hopkins Medicine in Baltimore. We have Dr. Amanda Brigel, a gynecological oncology physician and assistant professor at the Division of Gynecological Oncology at the Oregon Health and Science University Hospital and clinics in Portland. I'm going to get to Charlie last. We also have Dr. Bonnie Maldonado, Senior Associate Dean of Faculty Development and Diversity and Professor of Pediatrics and Infectious Disease right here at Stanford. And the person that you haven't heard from yet is Charlie Blotner, who is a patient advocate dedicated to helping people be better informed about their health, research, policy, and the future implications of their disease. Charlie is also a social worker in training, graduating with a Bachelor of Science from Arizona State University this spring, and pursuing their Master on Social Work at the University of Washington starting in the fall. And Charlie is a Cure Forward Precision Medicine team member, Stanford Medicine X student advisor, and co-founder of the Brain Tumor social media chats on Twitter. Charlie's a brain tumor. So let's start with a brain tumor survivor. Let's start with Charlie, and then we're just going to go right into sort of a discussion about diversity, kind of trying to set the conversation a little, and then go into medical education and how diversity is important. So what's your story, Charlie? A little bit.
Yeah. So what brings me here today, obviously, so I bring the patient perspective to the panel, right? So I was diagnosed with a brain tumor when I was 13. Then I had awake brain surgery at 17 to remove that tumor. And so that's a very brief, kind of quick one-sentence recap of that. I suppose the diversity part that I bring to the panel is being someone who's transgender, someone who has navigated the healthcare system, trying to kind of find competent care as someone who's trans, and within a system that has providers who try their best to treat trans patients, but don't always know how. And the reason they don't know how is because their education system isn't quite teaching them how, or they don't have the research to look to help them get where they need to be. And so if we don't have the research to look to, and we don't have the training to help our current med students get to where they need to be as competent providers, then how can our competent providers help train the future?
So we have sort of a good representation of all stakeholders here. The medical student, the physician, the hospital administrator, the educator, the patient, and sort of like the layman, which is me. I don't really know a whole lot about the topic, and hopefully we can start by sort of setting the stage a little bit about diversity and before we sort of talk about what we can do to sort of advance diversity in medical education. So I don't know. So I figure we can sort of be relaxed about it and have a kind of informal conversation if anyone wants to jump in. So when we speak about diversity, we usually sort of think about race, or we think about religion, or we think about gender or sexual orientation. What is sort of the right way to frame a conversation about diversity, particularly if you talk about in context of medicine?
Are you looking at me?
Sure,
Okay,
yeah.
sure. Yeah, so I think that Dr. Maldonado set a really good stage earlier by looking at the diversity demographics and things like that, because really diversity is about a number of things. Throughout the field of diversity, it really started with race and gender and the way in which people identified that, and then it went on to include a number of other things. And now we're in this place where we can talk about, being a female who is black is different than being a female who is white. Being somebody who is gay and white and male is different than being, gay, white, and Latino. I mean, that all of these things then change the way in which the various institutions interact with you, the way in which you occupy the world, and the way in which the world impacts you. So I think that the question is broad, and so the answer is broad, in that diversity is really a number of things, including the way in which you think, the way in which you share yourself. I can't remember what the question is actually.
Well, it's sort of like, what's the right way to kind of think in terms of how do we frame the conversation about diversity? Because I don't know. I mean, one can say, well, we're all diverse in some way or another, right? We're all kind of unique, right? So it's a lot of times you don't want to be, I don't want to be put in the Latin box because, there are some sort of expectations that come with that. How does...
So let me just say briefly, I think I talked a little bit about this earlier, but we're all different. And I made an analogy. We don't live in a gray world. We live in a colorful world. We live in a world of diversity at all levels, from the natural standpoint, and by the way, hooray for March for Science Day, but also in the way we relate to one another. So I don't think there's one formula for diversity. I really think that we just need to be open to hear the voices around us and to understand what they're telling us and how we build that relationship. So, for example, when we work with women, I feel like we're getting closer to the point when you work with I don't know if any of you saw that the New Yorker cover article with the surgeons, and everyone posted their surgical women. And I think it's a great thing to point out the fact that, yes, women can be surgeons too, but we shouldn't say, well, here's the women surgeons and here are the male surgeons. I think the idea is just to make it something that is normal and everyday life, and to be expected, and we as inclusive as we can be with the people that we're working with, and to make that inclusion part of the normal conversation that we have. I think there is no formula, and we at Stanford have been talking about toolkits to help people do that. One way that you can start the process is by having our faculty, our staff, our trainees recognize the unconscious biases that exist around us. And not to say that those are bad things, that we should be ashamed, or that we should make those go away. That is who we are. I think we acknowledge who we are, and we just say, great, this is who I am, this is how I view the world, and you view the world maybe a little bit differently, but let's talk about where that common ground is. I really think that that's critical. It's that recognizing our differences and celebrating our similarities. I know it's very high level and kumbaya sounding, but the operational part really has to happen at the local level in terms of training people to recognize that this is the real world. Because otherwise we'll say, well, I'm different and I don't really care about what that person is doing because I can't change myself and I can't change them. And that's really where we don't want to go down that path, I think.
So what?
I think to bridge off of that, in the context of medical education, where we go with diversity, and we heard a lot about the changing patient populations, and I think one of the things that we have to keep in mind when it comes to health professions education as a whole is when you're in a particular area, you want people who kind of have an understanding of the needs of those patients who are in your service area. So if you're thinking about, well, what could this look like for, I think it's two sides. What can this look like for education as a whole? And then what can this look like for education on a local level? And I think when you get to the local level, you begin thinking about who is your patient population, and do you have a workforce, a wide clinical workforce that kind of can talk to the different distinctions that your patient population has, whether it's urban versus rural or race, ethnicity, gender, whatever it might be, to make sure that you kind of have those pieces in place so that as you start to create that inclusive environment and culture at your institution, you kind of can bring together multiple stakeholders who kind of share those similar perspectives as patients, as well as the patients from the communities to bring in as well.
Right.
And I also think, going back to what you were saying about a formula, I think we can't come to have to expect that we're going to have a formula about diversity, because if we do and we think that there's going to be one end result of thinking of, well, we need to have a standard or a quota of what diversity is, then we're going to come to expect all Latinx people to look the same, or all trans people to look the same or transition the same way. And that's not really correct, and that will just lead us to these stereotypical assumptions.
Right. There are, so as I'm thinking, is this sort of a problem that kind of the same in throughout sort of the U.S.? I don't know. I'm thinking, is that if you look at medicine, let's say outside of the U.S., is there concern with diversity inclusion? Do anyone sort of have any insight to provide in terms of that, or is that something that we're mostly concerned about, or is that?
Well, I work in global health,
Right.
so I have a little different perspective on this. I work in many other countries around the world, primarily in preventing infectious diseases in children. So I have a very interesting perspective from the standpoint of looking at the patient, looking at the systems, and then looking at working interactively with government. And I would say that people are starting to become aware of these issues around the world. One of the things that we didn't really talk about, which really impacts diversity and inclusion, is globalization, our access to the internet, to information on an instantaneous basis. And I can tell you that my colleagues in sub-Saharan Africa have equal access in most cases to the information that we're looking at today. So they see what's going on, and I think it does empower people to feel like, we can start working in those areas as well. Now, obviously, again, I talked about distance traveled. I think there's a bigger distance for people in some places to travel than others. But the idea that we need to, for example, gender is a big issue around the world that you can't help but recognize in the media now. So we know that it is becoming more important, and I think people are just becoming aware of how we can be more equitable at a global level.
And I'm thinking there is a role, and I think Dr. Briegel and Dr. Trevino, we talked about this a little bit in terms of the role for mentorship in helping sort of advance diversity. Maybe either one of you can sort of expand a little bit on that. You've had some experience with a program that you ran with the folks in the bus, and maybe you can expand a little bit on that, if you can, and you speak about your experience, Dr. Briegel.
Sure. So I think mentorship is incredibly essential. If you don't have someone that you connect with, either as a female or a Native woman or your sexual orientation or whatnot, if you don't see someone who is 5 years, 10 years ahead of where you want to be, how do you start dreaming to be that person? And I think, I met Native physicians through the Association of American Indian Physicians, but when I made the decision to subspecialize, there was only one other Native American GYN oncologist in the country, and I didn't meet her until after I completed training. And so it's kind of uncharted territory, and I think whatever we can do to provide these mentorship roles in any capacity that we can, that is only going to help our communities.
Yeah, and I think going off of that, the Tour for Diversity, we work with mentorship usually from that high school to undergraduate to getting into professional school level, and through other organizations, there's that bridge from medical school to residency. But one of the biggest struggles that we still face is, like she mentioned, what do you do when you get into subspecialties? What do you do when you get into higher academic medical education? And just, that those bodies aren't there. It's a very different world when it comes to the mentorship as moving forward in the career advancement, simply because we know that There's a lot of uncharted territories. There's still a high need, but at the same time, we have to figure out how do we get people into academic medicine if that's one path. How do you get them to stay? How do you get them to mentor? How do you balance all of these extra responsibilities that now come with that as well? And I think it's an area where I know there are some organizations doing some great work to start getting the word out, but we still have a long way to come, especially when you look at those faculty numbers, whether it's gender and specialty and subspecialties or race, ethnicity, other demographics with the physicians as well.
And I'll say two things quickly about mentorships. Most of the literature that's out there, regardless of industry, around mentorship is primarily based on mentees, the impact of mentees, which is fantastic. I mean, the data is very strong. To be mentored is always a positive, thing, very typically a positive thing. However, there's a lot of good things that occur to mentors as well when you give back. And unfortunately, the literature isn't as strong on this piece, but by and large, if you are a mentor yourself, there's a lot that breeds success for you, that impacts you on a positive basis. But the second thing is that for schools of medicine and in general the academy, there are still some structural biases that exist that preclude faculty to be seen in a positive light or to be impacted positively in their tenure process as a mentor. So if you mentor individuals who are part of your background or are see you as a female who they want to dream to be, you couldn't. There's not a really strong way in a standardized process of tenure to say, oh, look, I pulled all these people up, with me. And so we as an institution and we as advocates really also need to look at those structural biases that exist so that doesn't preclude somebody who wants to be a mentor and wants to give back, that they say, you know what, I need to publish 100 papers. I really want to help you, but I got to publish because this is the way that I'm going to get an associate. So those are some other things that we need to think about in mentoring.
Yeah, that actually, there's a couple of really good papers from a group, I think, at Florida State. They discussed that as being a minority tax on career advancement, where because that's not something that's necessarily highly valued for career advancement, but everyone's still telling them you need to mentor, you need to outreach, you need to go do these things, it adds on this extra little level of, well, how do I accomplish everything that I need to? How do I meet my clinical goals in research and teaching? And now you're telling me I have to mentor and do these things, but not get any real credit for what I do.
So one of the things we did at Stanford is we were able to secure some grant funding to study. Actually, we were looking at work-life balance issues and looking and tracking what women and men did in terms of their daily lives and how much work they did that was service-related that really didn't count towards any either financial or academic credit. And then we would reward them for some of this work. And we've actually generated a fair amount of data looking at the patterns of what people do. And it was helpful to see where people put their effort when they aren't getting credit, but also even to provide a small incentive to people. It is really valued and appreciated, and it leads to a lot of positive reinforcement. So one of the things that we're trying to do now in some of the departments of the School of Medicine is to put some value on that activity. And we have something called RVUs, which is relative value units. It's how we code for procedures and for visits, and that's how essentially people get reimbursed for their clinical care. And we're trying to develop other areas called academic value units or education value units, where you give a little bit of credit for the other teaching and service work that people do. And the amount is obviously not going to be as large, but people really feel encouraged that they are able to at least be acknowledged for the work that they do, and it builds a better rapport around people who are putting this extra service in. We used to call it cultural taxation without representation. And so that's helpful. The other thing that is happening across the country and here at Stanford as well is developing more cultural competency curriculum for the School of Medicine so that the students can actually see how they're going to be dealing with patients who are different and what to expect. For example, looking at gender, sex, religion, all of those things, people say, well, why is that really important? But there are many, many instances of when knowing the gender the sex, the religion of somebody might affect their clinical care. It might affect the kind of medication they get. It might affect, for example, the distribution of a drug through the body. So these things are actually important, but may be dismissed as, well, you're just trying to find out about my personal life. And everything that a care provider does is to actually improve the medical care of the patient. And the more we value those differences, the better off we are. I'll just say one last thing. I didn't know this until recently, but it turns out that the vast majority of all the research that's been done at the national level on mice has been done in male mice. And so that's been changed. We now have to have equal representation among, or at least you have to justify why. And why is that important? It's not that we care about gender rights for mice. It's because if there is a gender difference in the way a drug is used or any kind of therapy is given, that does not come out in any of the research that we've ever seen. And so we're giving people treatments that were based on one gender alone, and that has had significant safety effects and consequences for women and children and others. So these are things that actually really affect medical care.
And speaking to curriculum, so Stanford had a study in, I believe it was 2011 here, in regards to the amount of time spent educating on LGBT-related topics in medical school. And the average amount of time spent on these topics was 5 hours. And this was across, I believe it was 150 or so different medical schools. And so 5 hours, so the average was 5, and then a third of those ended up being 0 hours spent on LGBT health topics. So 5 hours is hardly enough time to even cover the G, let alone the L, the B, and the T. So if we're not putting in the time to educate our students on these topics, then we can't expect them to go into the clinic and into the hospital and elsewhere and be able to competently treat their queer patients.
Right. So this is kind of I don't know. This is one of those questions that's sort of been a little bit nagging at me in terms of if we establish that sure diversity is a desirable state and that's what we want. So what is the role of colleges and universities that cater specifically to certain groups like the predominantly black colleges or Hispanic institutions? How does how do we justify the existence of groups like that if we're sort of seeking a diverse mix of providers and participants, students? How does that work? What's the role of those?
Well, so for example, the historically black colleges and universities came up because those populations weren't being admitted to traditional schools. At some point, it might be, again, I can't speak to the whole academy around that issue, but if you exclude people, they have to have a way to be trained. So, obviously, that filled a need for a group of people. And I also take a little bit of exception to saying, well, if we think diversity is important, diversity is here. It is a fact of life. And we all are diverse. So whether or not we want to make it happen is not the question. The question is, how are we going to deal with diversity? So that I would just change the wording a little bit. For example, the Student National Medical Association and the National Medical Association is the African American or the black arm, if you will, the black version of the American Medical Association. And why did they do that? People say, well, why do they want to have their own organization? You can argue about why that's good or bad, but the reality is the organization came about because they were not allowed to be members of the American Association. So we can't really turn it around and say, well, let's exclude those people, but wow, why do they want to have their own organization? Well, because again, we have excellence across the board. People, there's no as far as I'm aware, there's no genetic marker for intelligence and excellence. I think that is really that's a multi-dimensional. I didn't have time to talk about this, but if you look at who we are, genetics is 20%. Lifestyle is 20% and environment is 20%. 60% of who we are and how our life course goes is all social and cultural. And those effects from before we are born impact who we're going to be as we go forward. And so that is really does not see race, color, gender or any of that. It just sees where you were in a zip code, for example, or what your family was like. And so I think in general, we need to just be a little more aware of the fact that people have tried to develop these organizations so that they can advance their groups when they were traditionally left out.
Many of your institutions may have employee resource groups, ERGs or affinity groups or BRGs, business resource groups, which are based in some sort of primary, so a demographic, so an African American group, a Black women's group, LGBT, employees who gather together because of that common demographic, and they navigate together. They want to interact together. They want to network together. They want to learn, together. And so the definition of diversity doesn't, right? I mean, it doesn't exclude one or the other. So this is not an or conversation. This is an and conversation. We still have these predominantly white institutions, these predominantly whatever majority institutions, while at the same time we also have these HBCUs and other institutions that still permit individuals to learn in a common space with with individuals from their background. So this is not the preclusion of, this should go away and this should live right here. The fact of the matter is that America is still, ruled by and still has a majority culture that lives inside of the United States. And so these institutions, these affinity groups, these HBCUs, these, minority colleges and institutions exist because we're still trying to find a really strong balance and the value of how everybody is a part of this country. So again, I would really push that this is still this is an and conversation, this is not an or.
Yeah, reminds me of Dr. Bruegel said something about diversity is not really about making us comfortable. Right? What exactly do you mean by that? It was
just that, diversity isn't necessarily easy, and you don't have to be comfortable while seeking it.
Right.
You can try to be a more educated person with a particular group, and it's not just going to, because you have that desire in your heart, does not make it so. And I'm just going to talk a little bit what we were talking about backstage. I trained in the South and grew up in the Midwest, very small populations, and I didn't have much exposure to the transgender population at all. There's a significant population in Portland. We have a very welcoming division, but I'm learning language to ask about pronouns, and I make slip-ups all the time, and my patients are wonderful and they are forgiving, but it's not easy. I have to think about it. I have to think, this person said they want they, their, them as their pronoun, and so I have to use that muscle so painfully every time until it becomes natural. And so diversity isn't an easy button that you can say, I want it. It's going to happen. It's going to take some work, and it's worth the work.
Yeah, putting in that work.
Right. Yeah, I think we're just right about out of time, and so I wanted to sort of like wrap it up with perhaps a thought from each one of you on what should we all sort of remember or keep in mind or bear in mind in terms of when we think in terms of diversity and in the context of medicine. It would be lovely.
I think that as providers, I guess I'll start as educators. You have the responsibility to teach your students competently about the disability community, about the Native community, about immigrants, about all sorts of communities that you'll be interacting with. And then as students, students have really the right to know and learn about the communities that they're then going to be working with, so that when when they interact with us, when they meet a trans patient, they're not asking me how to treat me, because I'm not the one who went to medical school. And then as patients, we deserve competent care, and we hope that that you'll be willing to put in the work, to put in the work like you're doing to provide that care.
Medicine is the only industry in the globe where you walk into a room and you can tell somebody to drop their pants, complete stranger, and they'll do it. And you've kind of got your way because you're a doctor or you're a provider, and that's what you're there to do. That's a very, very large amount of responsibility. And to be able to take that on and to care for your patient, to enlist trust in some form or fashion, really asks all of our providers to understand who that patient is, who you are as a provider. We did not talk about that a lot, but also to understand who it is that you are as a provider and how that interacts, with one another. I mean, Spider-Man said it best, right? With a great power comes great responsibility. And so understand, I would push that in medicine. We really do have this amazing opportunity to create trust and to provide the best quality care to our patients. And diversity, inclusion, and cultural competency is a critical, if not, in frankness, one of the number one components to do that.
I think, one piece when it comes to this idea of the diversity 3.0, even as a student, you can find ways to say, well, how do we move this past this conversation of is this important? How do you find ways to integrate this into the larger mission of the organization that you're with, whether it's a nonprofit, whether it's a academic health center, but continuing to work to how do you bring diversity inclusion into the general fold of the mission responsibilities of the organization, and move that forward.
Any other thoughts?
I just want to urge all of you as medical educators in many different forms to really seek to understand how we can better move this diversity 3.0, that is the excellence, and bring that to our trainees in whatever way you think you can, and to seek out resources to try to educate yourself about how you can do a better job. We can always do a better job at integrating our experiences for our future workforce, because these are the medical educators and the academics and the physicians of the future, and that it's a big burden, but it's a wonderful burden to have, and seek out those resources.
I guess parting comments for me are, as whatever role of leadership we're in, I think we have to remember to be vulnerable. I need to talk to my female residents. What does it mean? You want kids one day. What is that going to do to my career? How do I share my culture? We're used to being in this position of power and leadership. And it's okay to be soft and strong at the same time.
Thank you so much. Let's thank our panel.